All right, everyone. Thank you for joining us on today's expert webinar for the 2018 Malnutrition Quality Improvement Initiative Learning Collaborative. Today's session will be focused on the nutrition-focused physical exam. It will be a mini session to give you an introduction to the nutrition-focused physical exam and share with you some key recommendations and insights for performing this at your facilities. My name is Kelsey Jones. I'm one of the leaders of the Malnutrition Quality Improvement Initiative activities at Avalier Health, and we are really excited to be joined by Lori Granich today and Beth Mordarski, who will be introducing the nutrition-focused physical exam mini session and then sharing with you some guidance on how to perform an NFPE. Before we get started, I wanted to share a few housekeeping items with you. All of your lines have been muted, so if you do have any questions or if you have any trouble with any issues throughout the event, if you have any audio problems or anything, please use the chat function. You should see that either in the upper right-hand corner or if you hover over the bottom of your screen. For some people, it shows up down there. And you can send a chat to myself or any of the other hosts to let us know you're having any challenges, and we'll work with you to get that addressed. You'll see a button popped up here. You can select to send it to the host, and then I'll receive your information and can assist you with any problems. So as I mentioned, Lori Granich will be introducing our session in just a moment, and then we'll hand it over to Beth Mordarski, who will be leading us through the nutrition-focused physical exam mini session. At the end, we'll have about 5 or 10 minutes for questions. Again, please hold all questions till the end, and please send them to us via this chat function, and then we can pose them to our expert speakers. So without further ado, I'm going to hand this over to Lori for a brief introduction of the session, the objectives, and our expert speaker, Beth. So Lori, please feel free to take the ball.
Thank you. So I'm Lori Granich, and I'm the Director of Lifelong Learning and Engagement at the Academy, and it is my pleasure to welcome my colleague, Beth Mordarski, as your expert speaker today. Beth Mordarski, RDN-LD, is the NFPE Program Manager for the Academy of Nutrition and Dietetics. She has over 17 years of clinical experience, which assisted Beth in the development of the Academy's nutrition-focused physical exam hands-on training workshop and NFPE pocket guide. Along with managing the NFPE program, Beth is also an NFPE workshop trainer. She finds it rewarding to be able to pass on the NFPE skills to fellow dietitians across the globe. She enjoys being a dietetic intern preceptor for graduate students and actively participating in research related to NFPE and malnutrition. So I will start us off with the objectives of the webinar. The first is to identify physical findings that may indicate malnutrition, including loss of subcutaneous fat, muscle wasting, and the presence of nutrition-related edema. Recognize the signs of common micronutrient deficiencies using nutrition-focused physical exam of the hair, eyes, oral cavity, nails, and skin, and incorporate best practices for NFPE into everyday clinical practice. I will now turn it over to Beth.
Thank you, Lori and Kelsey. I'm very excited to be presenting today to the MQii group on an introduction or overview of the nutrition-focused physical exam as it relates to malnutrition. Now, before we delve into the details of NFPE, or again, the nutrition-focused physical exam, it's important to have some background. Research shows that nutrition intervention of a patient with or at risk for malnutrition can decrease length of hospital stay, falls, pressure ulcers, infections, complications, readmissions, and overall healthcare costs. And this is important because we need to be able to identify malnutrition to provide the appropriate diagnosis and, in turn, intervention. A nutrition-focused physical exam can be performed by a dietitian to systematically, from head to toe, and we're going to hear that a lot throughout today's webinar, from head to toe, more accurately provide individuals with a nutrition diagnosis of malnutrition. While the NFPE is only one component of the nutrition assessment, it can provide the necessary supportive data to identify and diagnose the patient with or, again, at risk for malnutrition. NFPE is something the dietitian should be doing. And I say that because oftentimes we hear that that may be a barrier. Is this in my scope? And I'm here to let you know, yes, it is. It is a part of the RDN's standard of practice or scope of practice, in addition to being a part of the complete nutrition assessment. As we can see here, the NFPE is one of the 5 domains of the NCP, or nutrition care process. So along with our client history, our food and nutrition related history, gathering our anthropometrics, looking at the biochemical data, medical tests and procedures, we as dietitians should be performing an NFPE so that we are able to provide a complete nutrition assessment. Now, to help with diagnosing malnutrition, the Academy and Aspen came together and published the Adult Consensus Statement in 2012, which I'm sure most of us are aware of, but it's always good to review and kind of maybe find out a little bit more clarity on some things here. The Consensus Statement provides 6 malnutrition characteristics to identify malnutrition, and we can see here that out of those 6, 4 are highlighted: fat loss, muscle loss, edema, and reduced hand grip strength. These 4 are part of an NFPE, and that's important to point out because as a dietitian, if we're not able to perform an NFPE, their ability then to identify a patient with malnutrition may be limited. Now, the consensus group indicated that a minimum of 2 of the 6 characteristics need to be identified to diagnose a patient with malnutrition. You can, of course, have more than 2, which will provide additional supportive data. And I definitely encourage that we document all that are present. And I say this because oftentimes I've heard dietitians mention, well, my patient meets the requirements for decreased energy intake and weight loss. Why do I need to do an NFPE? And again, the more supportive data we have, the better. In addition, the patient may be at one level right now with the oral intake and weight loss, but as they unfortunately maybe stay in the hospital, may progress to do less well, or the opposite, they may improve, but you're having a harder time to assess that. If you would have done the NFPE on baseline, you have those data that's documented to be able to compare to. Also in the adult consensus statement, it's important to point out that the criteria is provided for non-severe, moderate, and severe malnutrition, as the consensus group could not indicate or couldn't find enough evidence to be able to differentiate between mild and moderate. Also, with the moderate and severe malnutrition criteria, it's broken down a little further into 3 categories: acute illness or injury, chronic illness, or social and environmental circumstances. So now that we have some background, let's discuss the 2 types of NFPE. We have focused and comprehensive. For a focused NFPE, that's based on the patient's medical condition or diet history. We may be looking for specific signs and symptoms of a vitamin or mineral deficiency, for instance. If a patient is having severe diarrhea, I may be focused on signs and symptoms that relate back to a zinc deficiency. But every time I want to do a comprehensive NFPE, and that is, again, the complete exam from head to toe in a very organized, systematic way. Now, I say that all the time I'd like to do a comprehensive exam. However, there are times when there's going to be limitations, and that is okay. It doesn't mean not to do any part of the NFPE. For instance, you have a patient in the intensive care unit, you may not be able to assess their back, so the muscles around the scapular region, for instance. And that's okay. You may be able to assess a lot of the other areas that we'll be discussing in a little while, and you're still able to gather enough evidence, data to support your diagnosis. So don't shy away from doing an NFPE even when there's limitations. Now, there are 4 techniques to an NFPE: inspection, palpation, percussion, and auscultation. Today, as we discuss some of the components of NFPE, we will concentrate on inspection and palpation because we consider percussion and auscultation more of advanced skills. And today we'll just concentrate on the inspection and palpation. For inspection, we are observing using our sight to assess shape, color, texture, and size. And then for palpation, we are feeling the texture, the size, and the tone using light to deep palpation touches. Now, when we're getting started, we of course want to wash our hands. we want to explain to our patient the process. I normally will say, hi, my name is Beth, I'm the dietitian. I'm working with the doctor or Dr. So-and-so, and wanted me to come in and talk to you a little bit about your nutrition. How have you been eating? I want to do a physical exam, which is helpful to give me a better picture of your overall nutrition status. It's something where I'll start at your head, work my way down. It's nothing that will hurt. Do you have any areas that are sore or painful or tender? I'll make sure that I avoid those areas. Thanks. And I'm washing my hands, I'm walking towards the patient. I want to make sure that I've ensured privacy and I optimize the environment. So I close the curtain or the door, I turn off the TV. I make sure my patient is in the right position. The bed is elevated as much as the patient can tolerate, or patient sitting in a chair if it's able and appropriate. And then I begin with my general survey, as we all do when we walk in and see our patients. What's their body habitus? What's their affect? Are they alert? Are they able to communicate? Or am I not going to get much information from them? It doesn't mean I still don't talk to my patients, but we want to, again, do that general survey. And one thing that I really love about NFPE is the tools. We all have the basic tools with us at all times. So this can be done in an array of settings, from inpatient to outpatient to community. We just need our hands and eyes. So we're all ready to go. Now you also see that I have the PPI, or personal protective equipment, there too. I normally, if the patient is not on isolation precautions, I'm not going to wear gloves. And that's because I want to truly feel the texture of what I'm touching, from the muscle, the fat, all the way to when I'm assessing for micronutrient deficiencies. Now, if your facility requires gloves no matter the examination, please follow your facility's requirements. And of course, if a patient is on isolation precautions, I am gowning up, I'm gloving up, I'm doing all the appropriate precautions. You can also see some of the secondary tools. I most often at this point I'm using my pen light so that I can look into the eyes and in the mouth for some additional micronutrient deficiencies. So now we're ready to get started. And so we're going to go a little bit more in depth now and talk about our fat loss areas, our muscle wasting areas, and talk a little bit more about edema. So to start with the subcutaneous fat loss regions, we're going to be looking at our orbital fat pads, our buccal fat pads, triceps, and ribs. We're going to be going from head to toe. When we're assessing for subcutaneous fat, we want to assess those fat pads under the skin. We want to see if there are bony prominences. Do we see loose or hanging skin, which again are signs of losses? So to jump in from, again, head to toe, orbital fat losses. So here we're up in the eye region. We are right underneath, and here I usually use my index finger and middle finger and gently palpate under the eye. I want to feel the nice bulge of the fat pad. I want to feel some bounce back. If I'm seeing loose or sagging skin or dark circles or depressions, then I'm concerned with that mild to moderate to severe range in those severe hollow depressions. This is something also very important to just let your patient know what you're doing, since you're going right underneath the eye. Have them remove their eyeglasses if they are wearing glasses also. Next, we'll move to the buccal fat region. So here, again, we are palpating for the subcutaneous fat in the cheek region. That's our landmark, our cheekbone. We want to go below our cheekbone, above our jawbone. Again, using my index and middle finger, I palpate in that region. You can see from the arrow kind of where we're pointing to. Sometimes it is obvious and visible. It does not mean that I still don't go in there and touch, even if I'm seeing this. It may also help me to follow up with some questions. Have you noticed changes in your face appearance? Has anybody mentioned any changes to you? We want to make sure that what we're seeing and observing is different for the patient and not their norm. As some people's body habitus, let's say, right, is different. We're not all textbook. Here, though, we can see the loss in the buccal fat with the narrowing and some sunken depressions in the cheek region. Now we'll move to our triceps in our arm area. So here I have my patients bend their arm in a 90-degree angle. I often will support it with my hand on their wrist. With my other hand then, halfway between their elbow and their armpit, I am going to grasp onto their arm and roll down, not pinch, we don't want it to hurt, but roll down to separate the muscle from the fat. We want to assess how much fat pinch is between our fingers. To help make sure that we only have our subcutaneous fat in our fingers and not our muscle, we ask our patient to make a muscle. Or if they're not able to completely follow the commands, even extending their arm and bending it, you can then make sure that you only have your, again, subcutaneous fat in your grip, in your pinch. Is it nice and ample? Are the fingers almost touching in the mild, moderate losses? Or are your fingers touching with just very little space in between, just skin on skin in the severe range? The last area of subcutaneous fat that we're going to talk about is in the ribs region or our mid-axillary line. So here I will have my patient often sit up or lean forward, and I'll take my whole hands, the base of my 4 fingertips, and run it down their back. And I'm assessing if they, again, have that nice fat overlay of the ribs, or am I able to feel the depression in between each ribs. Here on this slide, you can see the depiction of a little boy where we see even the subcutaneous fat loss in his chest region. We're seeing the depression of the ribs on the chest area. Oftentimes, like I did mention, though, I will see it on the back, and that's where I'm assessing. When we talk about the mid-axillary region, that's only if a patient is able to stand. We talked about some of these areas are important on the position. This is one. If my patient isn't safe or stable enough to stand, I won't be assessing this area. You kind of run your fingers down their sides up to their iliac crest, and you want to stop kind of where the love handles are. And do you have a nice pinch, or is the iliac crest really protruding where there's no subcutaneous fat overlay? Of course, now I say this, if you have an athlete, again, most of my patients are not athletes, but if you have an athlete, then they may not have that subcutaneous fat. But again, that's big picture, that's looking at your medical information, and you're going to understand that that's not a nutrition-related loss. That person is somebody who doesn't have much body fat. Now moving on to our muscle wasting. Here we're looking at the temporalis muscle, the pectoralis muscle, the deltoid, interosseous, the trapezius, supraspinatus, infraspinatus, and then in our lower extremities, our quadriceps and our gastrocnemius muscles. As I went through that list, we're going from head to toe again. And what's important when we're looking at our muscle areas and for looking for muscle wasting, if it's nutrition related, it's going to be bilateral. We're going to see it on both sides. If we only see losses on one side, we want to step back and ask, could this be a non-nutrition related cause? Is it due to inactivity, a disease state, paralysis on one side, a recent surgery? So really, again, look at the medical chart and step back, look at the big picture. If it's, again, nutrition related, we're going to see that bilaterally. We do often see that the upper body may lose mass, muscle mass losses sooner than our lower body also. So starting up here at our head, we'll start with the temporalis muscle. Our landmark is our temporal region. Here I take, my 2 fingers and I palpate right around the temple region. We're going to go back horizontal, diagonal, and vertical. You can see from the picture of the skeleton how far back our temporalis muscle goes. So we're just going to start kind of at the corner of the eyes and, again, go back to feel a little bit over to the ear. We want to feel a nice, well-defined muscle. It's helpful to ask our patients to pretend to maybe chew gum to engage that muscle so we can feel it better. Or as we're doing that motion, do we feel the depression? Do we feel hollowing? Do we see it, as you can in this image above, where there are depressions in the temporalis area? Now we'll move down to the pectoralis muscle. Here our landmark is our clavicle bone, and I use most of my fingers, again, about all the 4 finger pads. I start in the middle of the chest, and I palpate with some pressure, and I always say purposeful pressure and palpation, where I'm pressing and pushing up. I want to feel that nice tautness in the muscle, and I want to see, am I able to get my fingers underneath that clavicle bone? If I'm able to, that is indicative of muscle wasting, because our muscles should be nice and taut, and our fingers should not be able to slide underneath our clavicle bone. This is also one where our clavicle bone, it's important to note that in women it can be visible, but not necessarily prominent. If it's prominent, now we're concerned. We want to really assess that area because that it can be indicative of that muscle wasting. In males, it usually isn't necessarily even visible. So if we're seeing it visible, we can anticipate there's some loss and want to get in there to palpate. This is also an area where position is very important. We want our patients to, again, have their head of the bed up as high to that 90-degree angle that they can tolerate, or sitting in a chair if they can. Their shoulders back in a neutral position, and their arms not resting on any arm rests, kind of just down at their sides. Think about that if you're sitting in a chair right now. If you slouch forward, you can tell there is a change and a difference in how you would assess your pectoralis muscle versus sitting back and having your shoulders back in a neutral position. Same as if you were completely laying flat. That also may not be the best position to be in when assessing that pectoralis muscle. Let's move now on to the deltoid. And here our landmark is our shoulder, or the acromion process. So to assess our deltoid muscle, we want to grasp our shoulder area and have the patient just lift their arm, again, to engage that muscle. And we can feel for the nice rounded curvature of the shoulder. We want to feel the tautness of that muscle as they lift their arm, or as you assist and help them lift their arm if they're unable to do it on their own. With this, we want to look at the patient straight on. Do we see the nice rounding of the shoulders again, or are we starting to see some squareness? Are we starting to see the prominent or protrusion of that acromion process? The acromion process is set back slightly off-centered from the shoulder to the back. You can kind of reach back there and feel it. Some people's are more prominent than others on a normal level. Again, talk and ask, but also by grasping and cupping your shoulder area, deltoid region, and lifting, you'll be able to feel the tone of the deltoid muscle, even if that acromion process is visible and there is no wasting of the deltoid. You'll feel that nice tone in that deltoid region. So otherwise with the deltoid, if there are squaring, prominent bones, decreased tautness in that muscle, we're looking at severe wasting. Now turning to the back, into the scapula region as our landmark. Here we're assessing our trapezius down the center of our back. And to do this, we want to, again, engage those muscles. Oftentimes, my patients are in their bed. I just have them kind of sit forward, if they're able to, and push on the heel of my hand while I reach around with my other hand and with the pads of my fingers again, run down the center of their back, around the scapula, feeling for the tautness of that trapezius muscle. I then come to the top, and that's where the infraspinatus muscle is, and I'm assessing, is that nice and taut on the top part of the scapula bone, or do I see some depressions, dipping, hollowness there, lack of tautness of that muscle, a tone of the muscle. I then come to the side of the scapula bone on the outside to feel for the infraspinatus muscle. Again, is that nice and taut, or is the scapula bone protruding? Am I able to, as I make my way around that entire scapular region, feeling for the muscle tone, able to slip my fingers underneath that scapula bone, indicating the decrease in muscle tone? We can see here that this child is leaning forward and has more of that scapula bone protruding. You can also see, if you look down slightly lower in the picture, some more evidence of also subcutaneous fat loss at the rib region, where we're seeing the depression there in the ribs. Now to our hand area for the interosseous muscle. Here we want our patients to make the OK sign and hold it. I always laugh. I'll ask my patients to make that OK sign. They do it and they release before I have a chance to assess the muscle. So I do ask that they press and hold it. This is one, again, very important to check both hands, because we do often find that the dominant hand does have a stronger interosseous muscle than the non-dominant hand. So you want to, again, assess both. You want to look at it also. You want to make sure you're getting to the interosseous muscle, not just the webbing at the very opening of the finger and the thumb. So get back there to feel the interosseous muscle while they're engaging it. Feel both. You can do this on yourself even right now, and oftentimes, again, you will feel the difference in your dominant and non-dominant hand. So important if it's the dominant hand to truly assess that one for that tautness of the interosseous muscle. Look for depressions. If you see some slight depression or a really deep depression, now we're seeing also wasting in that mild moderate range with slight depression all the way to severe wasting in the deep depression region. So now that we've talked about the upper extremities, let's move down to our lower extremities in assessment for muscle wasting. Here we're at the quadriceps. Now, again, positioning for a quadriceps, if my patient's in the bed, I have them bend their leg, and that way I want their thigh off the bed so I can really assess the quadricep muscles. If they're in a chair, I'll ask them to maybe pick their feet up onto a footrest, again, to get their thigh off of the chair so I can assess the quadricep muscles. I want to look for well-rounded and no depressions in the thigh region. I'm going to palpate. I'm going to feel on the inner side of each thigh region and the outer. I'm also going to come on top and kind of grasp the top of our thigh for our quadriceps to see if it can be reduced, or do you feel the nice tone in that thigh? This is an area that I always find amazing, where if you don't pull back the sheets, you can miss a lot. So important to pull back the sheet to assess for the quadricep muscle and to feel. As you will begin to feel your patient's quadriceps, you may then, again, you'll feel the depressions that are happening as you palpate along the inner and outer thighs, and then the grasp of the quadricep being reduced on the top. Our quadriceps kind of meet there at our knee, so it's important also to look at the knee region. We don't want our knee to be very prominent. If our knee is more noticeable and we're seeing little muscle tone in that region, or our knee is square and very prominent, then we're looking more at that severe range. And again, the position, you can assess the quadriceps to the knee in the same position that we did for the quadricep. And lastly, we have our gastrocnemius muscle here in our calf region. So when we're assessing for our gastrocnemius muscle, we really just want to grasp the bulb, our calf muscle right there. We don't need to keep moving up and down the leg. Really, just grasp that bulb of our gastrocnemius muscle. Here again, position-wise, I will kind of lift my patient's leg gently off the bed, just so I'm supporting their ankle, so I can, again, grasp that gastrocnemius muscle. I want to do that on both sides. Make sure there's no reason medically that one is more reduced than the other that isn't nutrition related. I want to feel for that nice, firm, well-developed gastrocnemius muscle versus maybe some shape and firmness, but just not as much. And you can have that patient point and flex their toes to, again, engage the gastrocnemius muscle while you're grasping it to feel the differentiation between a well-firmed, maybe well-developed versus that one is lacking, or a definite tissue reduction that's thin, flat, or no definition, that hanging skin also in that severe range. So now we've talked a little bit about the subcutaneous fat loss areas that we'd be assessing for and the areas we'd be assessing for in our muscle loss. Let's move on now to our edema or fluid retention. So here we want to correlate our fluid accumulation physical exam findings with other evidence. We want to monitor our weight because fluid can definitely mask weight loss and weight gain, right? We want to look at our input, our output. We want to look at our lab values and our vital signs. When we're doing our fluid assessment, we want to do this, again, bilateral assessment. Is it on both sides? Did they just have an injury to one leg, so it's not nutrition related? We want to identify it as mild, moderate, or severe edema, as we can see depicted here on the slide, the different descriptions. We want to assess the depth of the rebound time and how to do this. So often I will find fluid retention in my lower extremities of patients. I start down by their foot, keep moving my way up their lower extremities to see how high the fluid retention goes so I can document it correctly. I then will come back down, maybe mid-leg area even, and press for about 4 seconds and release. I can run my fingers over that area I just pressed. Do I feel a depression? How quickly did it rebound? Is it an obvious depression? And counting again for that rebound. Are we in that 3+? And if we are, then we need to also step back. is this nutrition related, or do they have a medical condition that's causing the fluid retention? CHF, a renal patient, maybe a liver patient. So it's very important, and I always caution in this area regarding our malnutrition clinical characteristics here. Edema is one that is tricky, and definitely not all fluid accumulation is nutrition related. This is one I use with caution, and I don't always use one of my two criteria. If I have two definite or more other criteria to support my analysis, I can comment on the edema as additional supportive data, but I wouldn't necessarily use it as one of my two. Unless you're seeing this patient with anasarca. You know their picture with very poor protein intake, and we're looking at that type of third spacing. Then we're leaning maybe more towards that nutrition-related fluid accumulation. So again, just being cautious there, but regardless, I'm assessing for a fluid because it's always important. It does mean so much in the weight. I may not be able to assess the weight accurately, and I want to know when I can. When I see the patient maybe a couple days from now or next week, has that fluid retention decreased enough where now their weight is more at their baseline. So moving on to micronutrients. Now, while micronutrients are not a part of the malnutrition consensus criteria, deficiencies in vitamins and minerals can indicate inadequacies in nutrient intake or malabsorption issues, and we include it as part of our nutrition-focused physical exam. As part of the micronutrient assessment, we assess for the abnormality findings from head to toe again in the hair or scalp region, the eyes, the oral cavity, which includes the mouth, the tongue, the gums, the lips, and the teeth. We assess for micronutrient deficiencies in the nails and the skin. So let's review a few of the vitamin and mineral findings. Now, this isn't an all-encompassing list, but it will give you some examples of what micronutrient findings we may see in some of our patient populations. So kind of starting here up at the top, at the scalp, we can see a sign of a vitamin B6 deficiency. These pictures are indicative of seborrheic dermatitis. That's skin that's flakes, it's scaling, it's waxy, crusty plaques. Most often found at the scalp, but we can also see it in the eyebrows and the nasolabial folds. As you can see in the bottom picture, that's indicative of it at the nasolabial folds. And we can see some of our patient populations that may be more at risk for this vitamin B6 deficiency, where we may be doing a more focused exam for this deficiency. In a patient with protein calorie malnutrition, our dialysis patients, sickle cell, those with malabsorption or on diuretics, those on anticonvulsants, oral contraceptives, or the TB medication. Also to point out, while we can see this in a vitamin B6 deficiency, this is also something, the seborrheic dermatitis, that we can see in patients with biotin or zinc deficiencies also. So now kind of moving down to our eyes. And when I'm doing an eye assessment here, I take my pen light, as we mentioned, as one of our secondary tools. And I have the patient look one way while I look at the whites of the eyes, and then I have them look the other way while I look in the whites of the eyes, making sure that I'm not shining that light directly into their eye. So here is an example of a vitamin A deficiency, and these are Beto spots. So you're examining the whites of the eyes for foamy grayish white lesions, as we can see here depicted in this picture. If you can imagine the eye as a clock, these lesions will usually show up around the 3 o'clock and 9 o'clock positions. It's found on the conjunctiva. And we may see this in populations with a limited diet, fat malabsorption, alcoholism, CF, and short bowel syndrome. This is one vitamin deficiency that I have seen in a person, in a patient that was an alcoholic. I've also had a colleague see the Beto spots in her patient population with fat malabsorption. She had the cystic fibrosis patient and also an intestinal failure patient. In both of these instances, the patient and or family member had reported to us that they were tripping over things at night or having difficulty seeing at night, so they were having the symptom also of the night blindness. The good news is that when a patient does have a vitamin A deficiency and it's repleted, the Beto spots do resolve. Micronutrients here we're looking at is iron. And so we can see an iron deficiency with the pale conjunctiva, colonychia, or pallor. So the pale conjunctiva, that's up at the eye region again, head to toe, and where I will ask my patient to kind of pull down their lower lid if they can do it, or I'll let them know what I'm doing before I do. And there I'm looking for a nice pink lining of the eye. If it's pale, that can, again, indicate an anemia. We want to step back, look at our big picture. Not only can it be an iron deficiency, it may be a B12 or a folate, a B6 or copper deficiency. So there can be a larger span of what those potential micronutrient deficiencies are. But again, we want to step back, big picture, look at our labs, look at what's happening with the patient to be able to identify which micronutrient we're looking at. The next one over is our nails when we're assessing. We want to feel our nails. We want to feel each nail. If we find an abnormality on the nail, it will be on every nail if it's nutrition related. If you only see an abnormality on one nail, then it's probably more due to a trauma. Maybe you slammed your finger in the door or something to that effect. So with colonychia, here we're going to see kind of spoon-shaped in our nails. It's a concave nail with raised edges. Oftentimes people say do the water drop test. So if you put a drop of water on a nail with colonychia, it would stay there because it's spoon-shaped. It would hold it. If you look at your nail and you drop the drop of water on that, it would roll off the sides because it's nice and rounded. With that last one, the palmar pallor, here we're looking at our skin. We're observing the color of the skin for paleness. And again, this not only is indicative of an iron deficiency, we may also see this in a vitamin B12, folate, or B6 deficiency. You can also see those patients who might be at a higher risk for iron deficiency with inadequate intake, blood loss, or excessive thiamine intake. Doing another micronutrient that can be related to some skin findings. And when we're assessing our skin, we're doing that head to toe, kind of throughout our entire NFPE. We're asking the questions to our patients. Have you noticed any changes in your skin? If you see something, you can ask, have you noticed this? How long has it been here? Here is a picture of the perifollicular hemorrhaging, and we want to examine the skin around the hair follicles on the legs and arms for those small hemorrhages. And we can also see a little bit there, some of the corkscrew hair-like in the second image. These are both signs and symptoms of a vitamin C, or it can be a vitamin K deficiency also. We may see this in patients with a limited diet, infants on cow milk, dialysis patients, malabsorption, or smoking. What I like to kind of point out here in the picture with the perifollicular hemorrhaging, and I apologize, I did not advance that slide as I was talking. Here we go. So this picture on the right side is the corkscrew hair-like, and then on the left side is the perifollicular hemorrhaging. And with the perifollicular hemorrhaging, this is one that I like to point out the importance or the role the dietitian can definitely play in NFPE in our interdisciplinary rounds here. One of my colleagues was seeing this patient after this patient had been seeing a wound doctor weekly for months, and the wound wasn't healing. The dietitian saw this patient with the perifollicular hemorrhaging, identified it, and had the concern of a vitamin C deficiency. She did request a vitamin C level, but didn't wait for it to come back since this patient had the signs, the symptoms, and a big picture showing vitamin C deficiencies. When that vitamin C level did come back, it was undetectable, but they had started supplementing that patient with vitamin C. And after 1 or 2 weeks, the hemorrhages resolved and the wound began to heal. So this is truly an illustration of the knowledge and the importance the dietitian has and our specificity. When we go in to look at a patient, I always say we're putting on our nutrition goggles, and the doctors, they're looking at the patients in their different goggles that they are trained to do. So we all want to be together as our team approach and what we can bring to our team. Again, the importance of looking at, could this be a nutrition-related finding? And we as dietitians being that detective and seeing yes, no, having the discussions with our team, do we need to consult dermatology maybe to look at the skin issue? So again, I love that story of the impact we can have as dietitians. Now let's look at the micronutrient zinc. So here we have pictures of dermatitis, And this dermatitis is crusting open sores. We can see to the picture on the right, the vesicobolus lesions. To the picture on the left is the nasolabial folds. We see those reddening, crusting sores in that area. We also may see some of the dermatitis in the diaper area. And again, associated with the zinc deficiency. You can see all the patient populations that are at a higher risk for that zinc deficiency. And again, this is an area where a dietitian had a very big impact. This was a patient who was having severe diarrhea and was not at that time being supplemented with zinc. We started supplementing the patient with zinc and improvements started happening. We don't want to wait till we see these signs and symptoms of these deficiencies if, again, we know the importance of what's happening. They're having severe diarrhea. Maybe that's something that we start to supplement the patient with zinc while they're having those episodes. But it's also important to know when these signs and symptoms occur, how important it is to, again, talk with our doctors and make those recommendations to begin those supplementations or repletion doses. So we've talked about a lot here. We've done a really nice introduction or review of NFPE, kind of from head to toe. But we would be remiss if we don't talk about some of those perceived challenges that we do hear about when performing NFPE. One of the first things is the knowledge. Have you been trained and adequately trained? Articles are great, webinars are great, but it's really important for dietitians especially to participate in person hands-on training to really develop and hone in on those NFPE skills. This not only is beneficial to optimize your NFPE skills, but also to optimize your documentation, which then leads into the challenge of time. If we optimize our documentation, we can also decrease the time it takes for us to do that. Also, while NFPE may take some more time when you're starting out, as you continue to perform the NFPE on patients, it becomes second nature and you become more efficient and it becomes a part of what you do in your nutrition assessment. As you, again, you increase your confidence and you develop those skills. Now this carries on to some of our challenging populations. As you can see there, geriatric, obese, ICU or critical care patients, and the neurologically impaired patients. These can be very challenging populations, but the one thing is the more you perform NFPE on these patients, the better you're able to differentiate the norms versus the losses. You want to always look at the big picture in these populations, along with assessing their functional status, as we may see changes in their functional status prior to seeing other changes in their muscles, their fat, or signs and symptoms of micronutrient deficiencies. And so important to work with other disciplines. Here's one: you can time your exam when the nurse may be turning the patient, so you can assess the areas that may be limited otherwise. Now, as previously mentioned, we want to optimize our documentation. Work with your fellow dietitians and your EMR team to create screens for easy flow and checkoff boxes that can be pulled into your note. Have text boxes where needed for description. I find further description can be very beneficial, as another dietitian may be the one who's doing the follow-up or seeing a patient on readmission. So we always want to make sure we document appropriately. Now, to continue discussing some of the documentation, let's look at the PES statement. Here's where the dietitian provides the nutrition diagnosis of malnutrition when appropriate with the supportive data. The PES provides the problem, the etiology, and the signs and symptoms. Here's an example: severe protein calorie malnutrition in the setting of a burn injury related to hypermetabolism and increased energy requirements, as evidenced by 10% weight loss over a month and physical findings of moderate muscle wasting, temporalis and pectoralis region, and severe subcutaneous fat loss, orbital, buccal, and triceps. So a couple things here. I'm going to be more detailed in my findings with the temporalis, pectoralis region in my documentation where those checkoff boxes were. I'm going to be a little bit more concise here in my PES statement. Another thing to point out is where we see this PES statement could be used in the acute illness or chronic illness. What it depends is on looking at how long has the inflammatory illness or injury been there. Less than 3 months, we're going to go to the acute illness or injury. Greater than 3 months, then we're going to be looking at the chronic illness or injury categories from the consensus statement. And I do want to note the degree of severity is indicated here for the malnutrition versus just indicating malnutrition alone. And this is important to indicate the degree of severity in your documentation. Not only does it indicate to the medical team the level of malnutrition the patient has, but also this degree of severity can be beneficial in data collection to indicate the acuity of your patient population, which may aid in additional staffing needs. Also, the degree of severity is important to indicate for physicians' documentation so that coders are able to appropriately utilize the ICD-10 codes for reimbursement. And you can further refer to the Academy's ENCPT or Nutrition Care Process terminology for further reference on the nutrition diagnosis. So from the documentation, we can see the impact of a patient with and without malnutrition diagnosis here on this slide when we're looking at reimbursement and acuity levels. So if we look at the second column, here we have a patient with idiopathic spinal stenosis status post-fusion, and let's say we as a dietitian assessed and identified the patient to have severe malnutrition, but the doctor maybe didn't see our documentation and that it didn't get into the medical diagnosis. So the facility would receive the $45,766, and the patient would be with a SOI or severity of illness of a 1 and the ROM or risk of mortality of a 1. These SOIs and ROMs make up the case mix index or acuity level of our facility's patient population. And this is important because if we look at column 4 now, and this facility would have missed out on about $31,000 plus in reimbursement with the severe malnutrition diagnosis, and also an increase in the case mix index or acuity level. Another way to look at this is that this patient would be expected to do well because their SOI and their ROM is a 1, even though that may not be accurate. It emphasizes, again, the importance of identifying patients with malnutrition and communicating that information to the physician. So we have been given an overview of NFPE and the use in assessing for malnutrition. Let's talk about how to evaluate the dietitian's competency of NFPE and a malnutrition assessment. Dietitians should complete competencies of their NFPE skills annually or per your facility's policy. I think one of the most important recommendations to improve on your NFPE skills, comfort level, competence level, is to perform NFPE on coworkers, family, and friends. Perform NFPE on patients that are well-nourished, especially in those challenging populations, because then you're better able to differentiate those norms versus losses. Here you can see is a snapshot of an example of a competency form that can be utilized at your facility. And it could look like anything, whatever, again, your facility kind of develops, but just can stay with it and use it on an annual basis, at least for all your dietitians, and see where maybe additional review is needed then. Here we also have some NFPE resources, and included on this slide is the NFPE Pocket Guide. And I point that out because I know talking with dietitians, images are so important. And in the Pocket Guide, it's provided images of the subcutaneous fat loss and muscle wasting for well-nourished, mild, moderate, and severe in all those areas that we talked about here today in this webinar. So you can then compare what you have assessed to kind of what those images are. Now, while pictures are great, it still means you do have to go in and touch, because even though we see something, by touching, it may go, oh, it looked like it was wasted, but wow, I feel that tone. This is just this person's body. Or it looked fine, but oh my goodness, when I went and touched and palpated in that pectoralis region, that way there was wasting. There was no tone to that pectoralis muscle. And another great resource is the Academy's NFPE hands-on training workshop. So the Academy conducts these interactive hands-on workshops across the country with the focus on either the adult or pediatric population. And this workshop provides the RDN with the skills to perform an NFPE. We empower the RDN to accurately identify and provide a nutrition diagnosis for malnutrition for patients. We keep the ratio nice and small, 1 to 6, so that participants get really individualized training on how to palpate. They get to see their trainers do it, demonstrate it, and they get to do it themselves. We do some simulations. And what's really neat is, at the end of the day, it's so vital, we demonstrate, we perform these NFPE skills now on real patients during patient rounds to really feel from the well nurse that we did throughout the day to, unfortunately, those patients that are in the hospital, so we can feel the changes in the loss. We also provide ongoing support for all the participants who come to the workshop. So I encourage you, if you're somebody who hasn't had an in-person hands-on training yet, to think about joining us, or even your facility can be a host site. We come to you, the Academy trainers, we travel to you. Your staff will be able to participate in the workshop at your facility. Again, at the end of the day, do those guided patient rounds where your dietitians perform NFPE. You can visit the website at eatrightpro.org/NFPE to find some more information. And again, just how vital that in-person hands-on training is. The feedback has been wonderful. And I'd like to just share one, because I think it really shares the impact that it can have when we increase our comfort and confidence level through the in-person training. The Academy's NFPE workshop has taken me and my staff to a whole new level of practice. I highly recommend this training to stretch dietitians to practice at the top of their scope. So again, you can tell we're very proud and excited about the NFPE hands-on training workshop. Now, without further ado, again, want to thank you for your time and would love to do my best to answer any questions you may have on NFPE and malnutrition.
Thank you so much, Beth. That was a fabulous presentation and really insightful. Hopefully everyone on the phone had a chance to see some of the visuals and the resources that Beth outlined for doing the NFPE and can take something back to their practice. As a reminder, if you all have any questions for Beth or for Lori, you can click on the chat function that should either appear in the top right-hand corner of your screen, or depending on the WebEx platform you're using, you may see it as a little chat bubble at the bottom of your screen if you roll your mouse over that area. And feel free to send a chat to the panelists, and we can address any questions that you may have. So Beth, one question is related to kind of communicating about the NFPE to other clinicians in your organization. What's the best way to do so, and how do you kind of talk about those skills that you have to be able to perform that exam, and then how other clinicians should interpret and use those results?
Sure. So oftentimes, depending on if you're in the ICU, how close you are with your doctors, they're going to ask you what you're doing, which is a great learning experience, and you let them know. Or if you've already done it and you step out and you're talking to the physician, let's say, and saying, I did this nutrition-focused physical exam. What's that? And I just start to explain it. I always take these as wonderful opportunities to educate the other disciplines and say, well, I was assessing their muscle and their fat regions and putting it together. So, oh my goodness, they haven't been eating well, or they had this insult, and I was able to see in the pectoralis region, right there at the clavicle, they're having a lot of wasting. And I also assessed it here, here, and here. So when I put this all together, it indicates that they're in the severe range. So that might be something just on the floor. What you can also do is something a little bit more put together, let's say. And I've also done that, some lunch in services, or a 10-15 minute little elevator speech when you have time with your physicians or residents to be able to maybe provide them a few slides and let them know what you're doing so that they are aware and take that into consideration. Providing them the articles, the consensus statement, and showing them what this can do for them. Being able to have that supportive data in the diagnosis that they have to put again into the medical chart.
Great. And what are your recommendations on how often the NFPE should be repeated during patient stay in the hospital?
That's a great question. I get that all the time, right? So what I usually say is weekly, or if there's been a significant change in their status. But you don't need to do it every day. You're not going to see changes that quickly. The only thing that you would maybe is in that hand grip dynamometer for the functional status, but we didn't discuss that too much here. But yeah, so the fat, the muscle, things like that, I do it on a weekly basis. If I'm outpatient, of course, you'll just do it on follow-ups, things to that effect. But in the inpatient, I try to do it on a weekly.
Thank you. And finally, are there any opportunities to do more focused NFPE activities at FNCE?
Yes, another great question, right? So we do actually have a pre-FNCE NFPE hands-on training workshop. It's going to be on Saturday, October 20th, and we're holding it in Alexandria, Virginia, which is just right outside DC. And there are a few spots left, so if anybody is interested in heading to FNCE, encourage you to get on and register. You do get a lot of great resources. That pocket guide I mentioned. All participants get that pocket guide, a book, the PowerPoint, the ongoing support, in addition to the expertise of all the trainers that are there that day for that hands-on, intimate training.
Thanks, Beth. Actually, we got one more question.
Sure.
Related to your thoughts on the recently released Global Leadership Initiative on Malnutrition Guidelines, which use BMI as an indicator but do not necessarily use fat loss. More looking at reduced muscle mass, food intake or assimilation, and disease burden or inflammation.
Yes, so I am aware of that, and at this point, kind of taking it as it's another consensus statement from a group that decided that, you know, these were the important characteristics. So at this point, I wouldn't change the practice. I'd continue with NFPE, as that's really a part of both, along with the oral intake and the weight loss. So I kind of say those are the big four that we are kind of looking at, and the losses that we would see, the oral intake and the weight loss. So kind of more to come, but yeah, at this point, yeah. Good question. Yeah, I know it's there.
Very recent, very recent guidelines, so still trying to suss out exactly the implications for clinical practice.
Right.
All right. Well, if there are no other questions for Beth or Lori, we want to thank everyone for joining us today. Really appreciate your time. We will be circulating following this event a PDF of the slides, as well as information that you can fill out for your time attending this event today if you would like to receive CPEU credit for your attendance. If you have colleagues that were unable to attend but still would like to view the recording and receive credit for doing so, we also have a separate code for reviewing the recording after the event, so we will also circulate the link to the recording, and we'll share that online via the MQii Learning Collaborative participant-only portal as well. If you have any questions for Beth or for Lori or for our team at Avalier in the Academy that you would like to get addressed following this call, please feel free to send us any questions. You can do so by emailing malnutritionquality, all one word, at avalier.com. And we hope to see you on the next expert webinar. Thank you again for your time and attendance today.
Thank you.
Thank you.